Top Bed Talk.
Hello, my name is Dan Martin and I'm going to talk to you for about 30 minutes or so today about perioperative oxygenation, an ever-growing and somewhat perplexing topic. I think you'll all agree that oxygen is the commonest drug that we give to our patients today during surgery under general anaesthetic. We give oxygen before, during and after surgery, and the amount of oxygen that we give is determined almost entirely by anaesthetists. And because of these facts, you would have assumed that this is the drug that we know most about, that we give to patients during the time of surgery. But I would argue that it's probably the drug that we know least about, and I will try and highlight why I think that is during the course of this talk. So the last time I gave an anaesthetic, there were 3 rotameters on the front of the anaesthetic machine: oxygen, nitrous oxide and air. And it seems to me that nitrous oxide is now a little bit out of vogue, which leaves only 2 rotameters for us to think about when giving an anaesthetic: oxygen and air. And my recollection of the days of anaesthesia when I was still giving an anaesthetic was that there seemed to be more interest in the total amount of air and oxygen flowing through the machine rather than the ratio of oxygen to air. I'm going to break this talk down into 3 key questions given the Goldilocks theme of the session. And those questions are: how much is too little oxygen, how much is too much oxygen, and how much is just the right amount of oxygen. And if you don't want to know the answers to those now, I would turn the volume down. This is a spoiler alert. I don't know the answers to any of those questions. What I'm going to do, though, is try and illustrate why those questions are so perplexing with some of the evidence and background physiology that we have at our fingertips today. So the first of those questions, how much is too little oxygen, I want to try and illustrate by asking a different question, which is: why do we give oxygen at all during anaesthesia? And the reason that we give oxygen really is to prevent hypoxemia. So we give oxygen over and above the 21% that's usually in air because of the processes which cause arterial oxygenation to fall as a process of receiving an anaesthetic. So in many ways, the oxygen that we're giving is prophylactic to prevent hypoxemia. So in my mind, the aim should be really to achieve normoxemia during surgery. You will all be familiar with the oxygen cascade, which describes the passage of oxygen from the air that we breathe through the various physiological systems in the body all the way down to the mitochondria, where it's used to unlock energy in the substrates that we eat in a process called oxidative phosphorylation. There are various pathological processes which can affect the oxygen cascade. So developing diseases, for example, in the respiratory system will cause a limitation of how much oxygen can be delivered through the cascade down to the mitochondria. And as I've alluded to, one of the other ways in which the oxygen cascade can be affected is when we give someone a general anaesthetic, place them in a supine position, and then administer mechanical ventilation. And Andrew Lum very eloquently described these physiological processes quite recently in a British Journal of Anesthesia educational supplement. And what Dr. Lum did was to break these down into 4 physiological processes, all of which are affecting arterial oxygenation. So the fact that when we give an anaesthetic, respiratory muscle activity is reduced, there's a formation of atelectasis, we see alterations in the ventilation perfusion matching in lungs, going in both directions, both raised and lowered in different areas of the lungs, and the development of hypercapnia. So for these reasons, we give oxygen to patients to try and reduce the overall impact of hypoxemia during anaesthesia and surgery. And this is what a typical anaesthetic looks like in terms of the administration of oxygen. We tend to give up to 100% oxygen during induction of anaesthesia. This is then reduced to the amount that we choose to give during maintenance, and then back up to almost 100% or even 100% during emergence of anaesthesia. And it's probably the maintenance component which is the most important to our patients, as this is the time that they spend the longest in. And of course, beyond this diagram, we also need to think about how much oxygen we give after surgery. Just want to draw your attention to this paper published about 10 years ago now, led by Atul Gawande's group. They looked at about 95,000 patients undergoing surgery in 2 centres in North America, which incorporated almost 16 million oxygen saturations in total. And what they showed was just under 7% of patients experienced hypoxemia during the course of surgery, which I think is a pretty good representation of how good we are at preventing hypoxemia. What they also showed that is actually most of these cases were occurring during either induction or emergence, as you might imagine. If you look at the blue sector in the pie chart that's there on the screen, what you can see is more than 50% of patients actually spend most of the time with an oxygen saturation of 99 or 100%. Trainee anaesthetists in the UK have joined together trainee research and audit networks to look at this sort of thing in the UK, and 2 of the regional audit and network groups put together this piece of work where they looked at oxygenation across 29 hospitals in the United Kingdom. The numbers involved are nowhere near as big as the previous group. We don't have the luxury of huge computerized systems as they do in North America, so good old-fashioned paper and pen were used to write down the results from anaesthetics. But nonetheless, a great cohort of patients showing what oxygenation looks like during a typical anaesthetic in the UK. And what you can see here is the oxygen concentration given to patients during the course of an anaesthetic. The readings were timed in with each time an arterial blood gas was being taken as a routine part of the patient's care in slightly under 400 patients. And the interesting thing to observe here is that throughout surgery, from the first to the last blood gas, patients are being given 50% oxygen the entire time. When you look at the first 3 blood gases, and typically arterial blood gases are being taken roughly hourly during an operation, in some cases 100% oxygen is still being delivered at the time of the 3rd blood gas during surgery. When you compare this to the arterial partial pressure of oxygen from the blood gas reading, what you see is quite interesting. So basically, the partial pressure of oxygen is about 25 kilopascals throughout surgery, which is twice the normal oxygenation of a human being from a normal physiological perspective. And again, this number is not changing throughout surgery. So there's no titration whatsoever of the amount of oxygen that patients are receiving in order to titrate this level down to what we might call normoxemic level. So patients undergoing surgery are profoundly hyperoxemic in the UK. And as in the similar to the last slide, if you just look at those first 3 blood gases, you can see that the maximum partial pressure of oxygen recorded in some of those patients is really quite high, levels of over 60 kilopascals even into the 3rd blood gas. And this is not a phenomenon that is unique to the United Kingdom. This is a quote taken from an editorial written by Andrea Kurtz from the Cleveland Clinic, and what she said was pretty much the same findings that we showed in the small study just before, which is that there is a large range of oxygen being administered to patients having elective surgery, but most people in the study that she was involved in, which was for elective colorectal surgery, were receiving about 50% oxygen throughout the time of their surgery. So I'm going to move on to the second question now, which is how much is too much oxygen? And I want you to really think about what we might describe as the yin and yang of oxygen's therapeutic properties when working our way through this question, remembering that I don't actually know the answer to this question. And if you're not familiar with the yin and the yang and what it stands for, it's part of an old ancient Chinese philosophy, which describes something called dualism. And dualism is where you can often have perhaps opposing or contradictory forces working together to have a single beneficial outcome. And I think oxygen fits this very nicely, and hopefully I'll be able to illustrate that over the next few slides. So probably the best place to start when thinking about the extremes of administration of oxygen is where much of this all started, which is hyperbaric oxygen therapy. And during hyperbaric oxygen therapy, patients breathe high concentration oxygen at an elevated barometric pressure. And typically, patients are being treated at perhaps 2 or 2.5 atmospheres. And what this does is it dramatically increases the partial pressure of oxygen in the alveolus, in arterial blood, and ultimately in the tissues. And the sort of hypothesis, if you like, as to why this would be beneficial to patients with tissue injuries is because, number one, it not only adequately ensures adequate oxygenation of the tissues, particularly when there's impaired blood flow to tissues, as you might see in some wounds and vascular problems, but it also dramatically increases the production of reactive oxygen species in those tissues, which is believed to improve bacterial killing by neutrophils, as these neutrophils use reactive oxygen species as part of the process of the destruction of bacteria. Hyperbaric oxygen therapy has been used for decades now to successfully treat tissue problems such as gangrene, necrotizing fasciitis, and diabetic ulcers of limbs. And it's from this literature in the hyperbaric field that we started thinking about how useful this might be in a surgical setting. And the paper which really started this all off 20 years ago now came from Dan Sessler's group at the Cleveland Clinic. And what they did was to take the principles of hyperbaric oxygen therapy and just try and give as much oxygen as possible to patients during surgery to see if it prevented surgical wound infections, with the hypothesis there being that surgical wounds are often poorly oxygenated, and poor oxygenation can be associated with an increase in wound infections. So they conducted a randomized control trial of 500 patients, randomizing patients to receive either 80 or 30% oxygen during and for a few hours after colorectal surgery. And to sort of cut straight to the results, what they saw was about a 6% reduction in surgical site infections in the group receiving high concentration, so 80% oxygen. And this really set the scene for a whole raft of studies which followed it, sticking to this 80 or 30% comparison. So what that has set up over the last couple of decades is what we might call the oxygen dichotomy, whereas almost all studies since that first paper that I just showed you have basically compared 80 to 30% oxygen. Nobody's really sure why these concentrations were chosen, perhaps because 30% oxygen is about the amount that we should be giving to patients as routine care, even though that's clearly not what we do. And maybe that 80% is close to 100%, but not really sure why they chose 80 rather than 100. But nonetheless, over the years, these are the levels of oxygen which have been hotly debated and compared in a whole host of randomized control trials. So the advocates of the 80% oxygen approach to treating patients in terms of surgical wound infections is, as I mentioned, that this increase in tissue oxygenation as a result of breathing a higher concentration of oxygen increases this burst of neutrophil action, killing bacteria with reactive oxygen species. For those people who are more opposed to this approach and don't believe it to be the right approach in the perioperative period, their concern is that this high concentration of oxygen may cause harm in the lungs, leading to postoperative pulmonary complications. And I'm just going to explore that a little bit more in the next few slides. So this is a paper that I came across recently and is probably the only study that I know of that has compared 100% oxygen against breathing room air in patients for a prolonged period of time. There have been numerous animal studies showing the very clear consequences of breathing high concentration oxygen and how it causes inflammation of the lungs. But this paper published at the end of 1970 in the New England Journal really clearly shows you what high concentration oxygen can do to the human lung. It's a very small study, and what the people who ran this study did was just to take 10 patients on the intensive care unit who had been deemed as being brainstem dead, so they had irreversible brain damage, and randomize them to either receive 21% oxygen or 100% oxygen over the course of approximately 3 days. And the results were quite astounding. You can see on the screen just 2 typical chest x-rays, one from each cohort. On the left, you can see reasonably clear lungs in a patient from the air group, and in the right, you can see this sort of patchy, widespread consolidation in an x-ray from one of the 100% oxygen cohort. The investigators also conducted a whole series of lung function tests in these patients before, during, and after the intervention, which I don't have time to go into in detail, but they showed profound reduction in lung function in the group of patients receiving 100% oxygen. And the graph you can see on the screen here, what this shows you is the partial pressure of oxygen after a short burst of 100% oxygen in the patients. And what you can see is after about sort of 24 hours or so, this divergence whereby the patients, which are shown there in a red dot, which are those receiving 100% oxygen, paradoxically with very low arterial oxygen levels, and with the crosses after about 24 hours or so, much higher PaO2s when given 100% oxygen. So just showing you the damage that is caused by breathing 100% oxygen in terms of inflammation. So this sort of less is more group, if you like, those that do not believe that in the value of 80% oxygen for surgical site infections are perhaps rightfully concerned about the very thing that hyperbaric oxygen relies on for its treatment effect, which is oxidative stress due to the buildup of reactive oxygen species. And as shown by the chest x-rays in the previous study, this oxidative stress causes damage to the lungs in the form of inflammation, and in animal studies this goes on to develop into fibrosis. One of the other things that very high concentration oxygen does during the course of surgery is to lead to post-operative atelectasis, and this atelectasis is then hypothesized to lead to pulmonary dysfunction. What is also interesting in favour of the sort of 30%, if you like, is that the largest randomised controlled trial to date, the proxy trial, which compared 80 to 30% oxygen again, showed no difference in surgical site infections between the two groups. So these are all reasonable hypotheses and concepts to be wary, at least, of the 80% approach during surgery. One of the studies that's worth bringing to your attention is the study I've highlighted here in the British Journal of Anesthesia in 2017, which showed an increase in post-op pulmonary complications which associated with being given high concentration oxygen. The problem with this study is that it was a retrospective registry study. So the study was very large, it involved more than 70,000 patients, but because it was retrospective in nature, you cannot exclude from the results this issue of confounding by indication. So despite the fact that this group found that the higher the concentration of oxygen you received, the more likelihood was that you would have post-operative pulmonary complications, it is confounded by the fact that you tend to give more oxygen to the patients who are more unwell, because it's not a prospective randomized controlled trial. So whilst interesting, it's not necessarily conclusive. So the group who are perhaps more in favour of 80% oxygen for the reduction of surgical site infection during surgery have a whole host of reasons to support their views on this. I draw your attention to this review article that the reference on the screen here, recently published just a few months ago, with this word in the title that I've never come across before, Hyperoxyphobia, which I assume means a fear of giving too much oxygen during surgery. And actually the authors of this review really neatly put together some cogent arguments, both for and against the 80% approach. I'm just going to pick a few of the important ones out now to bring to your attention. One of the first things they say is that when you look at all of the randomized control trials that have looked at 80 versus 30% oxygen during surgery, there is, in all but 2 of those, there is a lower short-term mortality in the patients given 80% oxygen. Now they do caveat this with a fairly hefty dose of salt, which is that none of those randomized control trials were actually powered for mortality. They're always powered to detect a difference in surgical site infections. All of them therefore had very wide confidence intervals for mortality, and which also in fact crossed unity. But interesting nonetheless that the point estimates are tending to be in favour of the 80% rather than 30% approach. Recently there was a systematic review and meta-analysis published looking at the 80 versus 30% studies, and it's also interesting that the conclusions of that meta-analysis, so there was no association between oxygen concentration and short-term mortality, which could be interpreted that the 80% is not causing any excessive harm in patients in terms of pulmonary outcomes. And they also noted no increase in atelectasis either. But again, must be stressed that none of the studies in that meta-analysis were powered for those 2 outcomes. Also interestingly, recently published Andrea Kurtz's large but not randomized control trial where patients were on a sort of weekly basis allocated into either 80 or 30% oxygen during surgery. In a post-hoc analysis of this study, they showed no increase in post-operative pulmonary complications in the 80% group. So at least in some of the literature that's out there, they're not detecting any harm in patients receiving 80% oxygen. So although I've not gone into all the papers in detail because there are so many of them now, I think it's fair to say that in the 20 years since that first paper I've shown you, there have been approximately 20 or so randomized control trials of varying size and quality, and almost as many systematic reviews and meta-analyses, to be honest, often with the outcomes wavering between 30% or 80% being beneficial or nothing being beneficial at all. So I think what is very clear from all that is there remains a distinct lack of clarity about what we should be doing in the perioperative period. Just to confuse matters even more, in November of 2016, the WHO produced a guideline for all countries and all people to be following about how to reduce surgical site infections during and after surgery. There are a number of interesting things about these guidelines. Perhaps the most interesting thing about the guidelines is that no anaesthetist was involved in the writing of the guidelines. Nonetheless, what they concluded in their 2016 guideline, which was accompanied by an article in the Lancet Infectious Diseases journal, was that it should be mandatory for all patients undergoing surgery and being intubated for surgery to receive 80% oxygen throughout surgery and for up to 6 hours following surgery. And the publication of these guidelines caused quite a lot of interest around the world. I think it's fair to say that nobody really followed that guidance after its publication. What made things even more difficult is that a number of papers used in the systematic review and meta-analysis of oxygenation were then retracted, and even more concerningly, a number of them were reported to be fraudulent. So we're then in a situation where there's a WHO guideline based on retracted and fraudulent data. So they were forced to relook at the data, and this a further systematic review and meta-analysis was performed with those articles removed. And interestingly, even with those removed, the guidance basically remained the same, although the WHO did have to downgrade somewhat the strength of the recommendation involved. So really difficult to navigate yourself around what is becoming a very complicated area of perioperative medicine. So to the final question, which is how much is the right amount of oxygen to give to patients? This is what we really want to know. We want to be able to go away from this and say, well, this is the right amount to give to our patients. And as I told you at the beginning, I really definitely don't know the answer to this question. So I'm going to try and make you think a bit more about this question by presenting you with even more questions. So, is 80% the right amount of oxygen to give to patients? We have seen evidence both for and against it. Is 30% the right amount to give to patients? Again, evidence both for and against it. But perhaps we should just sort of sit on the fence and give 50% oxygen, which is what we're doing currently according to the studies performed in the UK and in the United States. If these are the three concentrations which are largely being given to patients, how are they linked in terms of benefit? Are these benefits linked in a linear or curvilinear way? Is 50% more beneficial than 30%, and is 80% more beneficial than 50%? Or do we have a sort of U-shaped relationship between these three oxygen concentrations? Is it the fact that this is a very difficult area for us to look at because for some people one concentration might be better than it is for other people, such that there is an inter-individual difference in what the optimum amount of oxygen is during surgery? Does it matter what type of surgery they're having? Largely these studies have looked at patients having abdominal, particularly colorectal surgery. Is there something particular about that surgery which is responsive to oxygen, or is oxygen important for surgical wound infections in all types of surgery? And perhaps to those of you more interested in the physiology of this, is which of the components of oxygenation is in fact the more important? It's the inspired oxygen concentration which we prescribe to patients, but it is in fact their partial pressure of oxygen in their blood, which is what their tissues and cells are seeing. So which of these should we be targeting? The amount that we give or the amount that we measure? So where does this leave us in conclusion? Well, I think it is probably fair to say that we should try to avoid unnecessary hypoxemia in patients undergoing surgery. 80% oxygen may reduce surgical site infections. To the best evidence that we have to date, this is probably the most accurate that we can be to say that it may reduce surgical site infections, but we're a very long way from knowing the absolute answer. And I'll just remind you that the largest study to date looking at this is only 1,400 patients. And to put that into some perspective, the latest study to begin looking at oxygenation in critically ill patients, the MEGAROX study, which has now started recruiting, aims to recruit 40,000 patients into it. And I think lastly, there is a possibility that 80% oxygen may lead to pulmonary complications and respiratory dysfunction in patients. But again, I think the jury is out for that, and we just don't have firm enough evidence to say that that is the case one way or the other. So I think I will leave it up to you to decide how much oxygen you give to your patients when you go back to your operating theatres for your next elective list. But hopefully in time we'll be able to answer some of these questions with further studies looking at these difficult but interesting physiological questions. Thanks very much.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.